Assalamualaikum. Our next speaker, Dr. FAISAL BATWA, he will speak on the personal and economic burden of inflammatory bowel disease. I think everybody knows him. He is consultant internal medicine, gastroenterology, assistant professor of medicine and gastroenterology in King Saud University, King Abdulaziz Medical City, Jeddah. And he is vice president of Saudi Gastroenterology Association, and I think we will.
Thank you, Father. Assalamu alaikum. So thank you for coming. I see the room is full, so hope you will find some useful information in this presentation. I tailored my presentation to the economic burden, so I'm not going to talk about the social, although I'm sure you see this in your practice. IBD has an impact: social, mental, sexual, work disability, economic. My talk today is really about the economics. We know that IBD ranks one of the top 5 GI disorders, the most expensive ones, and with an annual financial burden. I'm quoting the US healthcare because I have no much of data of other healthcare systems. 14.6 billion in 2014. That's even before the spark of the new biologics that came on in the market. And some estimates it to 31 billion if you add indirect costs and work loss. So it's a huge amount. We know that 1/3 of our UC patients will need surgery in about 30 years. 70% will need probably surgery at some point in their lifetime, and 1/3 probably will experience a recurrence in their lifetime. As Yasser mentioned, that's a progressive disease. And if you don't intervene early on in the treatment, then you're probably going to get into complications. And it's the 8th leading cause of OPD visits. So just imagine, this small disease is one of the top 10 that leads to OPD visits across the board. Among diabetes, other things in the healthcare business is IBD. New study published this year. I'm gonna mark this study and quote it, Park et al. Published in inflammatory bowel disease this year because it has the most respectable model of cost analysis of the impact of the IBD and the economics of it. We know that patients with IBD in the American healthcare system spends a lot in IBD, and they consume a lot. So their cost per patient per year is probably 3 times to 3.5 times other non-IBD patients. So for non-IBD patients, you can reach up to 7,000, but in IBD you can reach up like probably 23,000 US dollars. And the cost compared to other disease is probably going up much steeper than other disease. If you see this curve, so these are the controls. There's a steady rise and increase in the cost of these controlled diseases. For arthritis, there's some sort of analogy that is dropping a little bit. For Crohn's, skyrocketing. So why is this happening? So many things happening with the Crohn's. We'll come to that in a few minutes. We know that it has an impact on quality of life, changes the social, family structure, activities, social gathering. Patients alter their dietary choices, although we don't recommend something in particular, but they do have their preservations. Frequently, there is an experience that the patient needs for a caregiver, somebody to help him around, because for stomach, for bathrooms, children with IBDs, they're quite dependent. So the work age group, these are the patients that we treat. Our patients are between the 20s and above. And this is the time that they go into their work field. And they have a tremendous impact on their work capabilities. 17% of them have higher chronic disability, more than the general populations, and the cost is higher for them. And they tend to take more sick leaves. These are the documented ones according to studies. So it affects the workplace performance. Diarrhea, a physician on call, how can he make it? if it's not well controlled. I'm sure one of your patients is a physician in your practice. Compare it to the IBD patients. Taking sick leaves, a nurse has a shift, she cannot show up to her shift, so who will cover? That's a side story. But who's gonna pay her if you're paid by shift? And these patients tend to pay, in addition to their insurance, a co-payment because they need access or they need medications or they need investigations. So they have a higher out-of-pocket payment in insurance system, not in other places where there is no even insurance. So in insurance system, they need to probably twice as much as non-IBD patients. And the younger and the older are having the hit of this. At least 46% of them have a higher amount of money that they need to spend on them. So what happened? Did the cost stay steady? We see in 2014, something happened. What happened in 2014? The IBD guys. So why did the cost went higher? What do you think? Give me an idea. Physician's fees? Who says it's physician fees? Hospitalization? No? Surgeries? I see people sounding biologics. Since people are screaming about biologics. Yes. There is a big burden to the healthcare system coming from different factors. So if you want to look into the cost drivers in IBD, you have to break them down in direct costs and indirect costs. Direct costs related to hospitalization, surgery, physician services, prescription drugs, over-the-counter stuff, skilled nursing. How many of you have an IBD nurse? 0. No. Yusuf, Nahla, 2. I don't have. Fahad, 3. Only 3. Yani that's a rare skilled nurse, and you're lucky if you have one. Because us, like me, I don't have anything like that available. Diagnostic procedures, these are direct costs, but there is indirect costs. Absenteeism, lost earnings, lost productivity, leisure time. This is important that for the patients. And the cost of these are humongous. I look into a Canadian example that was 2012, and you can see that at that time, the cost was, for the indirect cost, is about 180 million, 160 million. So probably 50-50 or more for indirect cost. And they're calculating it about the time loss and the wages because the social system in Canada allows you to calculate such stuff. Not sure if you in other healthcare system you can replicate this material. But really, what happens in other studies in the American healthcare system, that they tell us that probably the majority of costs is related to pharmacy. 35% is pharmacy. And out of the 45%, these are the ones that drive the cost. So yes, for biosimilars. And I'm sure Afi will help me after this. So and when they look into which driver of the cost, and they analyze in the cost ratios of different stuff, you can see an outlier way above compared to the rest. So they're around the median. But this one is really shouting out in the sky. And see how much this cost has soared over the last decade and so. 5SA probably do well in the first year. They reduce the cost ratio a little bit, but then they pick up later. Still is not much. Biologics, steep rise. Ambulatory care visits tend to increase because you probably need to give instructions, medications, and so on. And that's an older study, so they counted up to 2004. But a new study by Park et al., they found that there is probably modifiable risk factors that we can work on that can affect the cost. So they only highlighted 2 issues, mainly anemia and mental health. And they found that, in addition to steroid, opioid, and ER visits, anemia by itself, finding anemia in the history, controlling other risk factors, controlling, adjusting for every other single factor, has an 8% higher cost. And prior treatment for mental health has a 5% increase in the cost. So there is other stuff we can work on that probably can fix the cost. And people work in models, try to find out, can we save some money? So this mathematical model, I'm not going to bother you with the whole schedule table here. They'll show you this table to show you that compared to other chronic diseases, like multiple sclerosis, IBD, and IBS, if you modify a couple of factors, you can probably save $15,000 per patient. Similar to multiple sclerosis, not far from it, and probably $1,000 for IBS. So there is a room for improvement. There is a chance if you do some stuff well, you can control the cost. So strategies proposed, and this is not something that has been studied. So these are probably the future of IBD studies in cost management. And this group, Park et al., by the way, so they through the anemia, they through the mental health, and they clearly stated, next publication will tell you exactly what is going to happen. And how do we analyze this factor? So probably you're going to improve the access to treatment. Be goal-oriented, quality-conscious. Do that. Quality saves money. Avoid healthcare resource utilization. Avoid complications, comorbidities. Optimize treatment regimens based on individual patient, individual therapy. And improve adherence and compliance. Be strategic. Target hotspotters. Who are the ones that you think that they need more attention to their risks? And if you modify them, you can work on them. And reduce cost. Work anemia, behavioral comorbidities. Look why they come to the ER. What is the reason for their ER visits? Check if you can do something about the biologics. Find the biosimilar if you can. Let the biosimilar affect the price of the originator. Yes, that's a good thing. Eventually, the prices should go down. Because each year or another year, we're getting a new molecule that costs 3 times the previous molecule. And work on the mental health of these patients. In my conclusion, IBD costs keep going up. Patient share of this cost is big and is quite limiting to them. And I'm sure you've seen patients in your practice that they don't have access to therapy. There is big room for improvement. And please be proactive and innovative in your approach. Devise a strategy. Negotiate with your payers. Negotiate with your hospital to provide your patients access. Provide them with better options, better treatments. Negotiate with your colleagues. Negotiate a network of function to these patients. They keep traveling. Add to the cost. They go to Shakir al-Riyadh, then they go to Majid, and they go to Abdurrahman al-Jibreel. What is this? And they keep shopping for opinions, and different opinions, different investigations. All of this burden the cost of our economy. Thank you very much for listening.